asking the audience for topics that they would like discussed during this year's curriculum. The request from several people was, could we please address the phenomenon whereby a person comes to a clinician and says, and they complain of a lead symptom. For example, I feel very depressed. And based on that symptom, they get a diagnosis of depression, but a lot of stuff goes overlooked, and then it turns out that that diagnosis was incorrect or incomplete. So there's not quite a name for that form of misdiagnosis. The last time I spoke, I talked about diagnostic overshadowing, which is a process whereby if somebody has a severe mental illness diagnosis, that diagnosis seems to cast a shadow over other phenomena, so that other symptoms are then assumed to be a reflection of the mental illness when that might be incorrect. So they call that diagnostic overshadowing. So I thought I would come up with the term symptom overshadowing to describe that phenomenon. And struggling for a catchy title, a symptom is not a diagnosis. This is going to turn out probably to be just telling you all what you already know, but I think there's still some value to reviewing how psychiatric diagnosis works, and specifically talking about the concept of differential diagnosis. It's an important topic because it's an open secret that a lot of times in psychiatry, the first attempt at treatment doesn't work, or it works incompletely. So treatment non-response or treatment partial response is extremely common. So common, in fact, that for major depressive disorder, we expect non-response or partial response to occur, actually, sadly, in the majority of cases. There are many, many reasons why a person is not going to respond to the initial therapy that was chosen, but having the wrong diagnosis at the start or an incomplete diagnosis is one of the leading causes of what appears to be treatment non-response. We're giving a treatment that would be right for major depression, but the person doesn't really have major depression, or they have major depression plus something else that gets in the way of treatment. And based upon the consults that I get, I surmise that one important cause of getting a wrong or incomplete diagnosis is that clinicians jump to a conclusion. So this phenomenon that audience members were asking for me to talk about, whereby a chief complaint gets translated quickly into a diagnosis, shall we say, it's not uncommon in the cases that I review, and thus symptom overshadowing. So let me give you some examples. Oh, I forgot to mention, I did try to look to see if there are any estimates for how often this phenomenon occurs, and I really couldn't find any based on any of the search strategies that I used, except for this one. I did come across papers along this theme. For example, in people that have type 1 diabetes and they're given this PHQ-8 or PHQ-9 screening, which is very, very popular in primary care practices and actually in psychiatric practices also. So based upon a PHQ quick assessment of symptoms, you can either use cutoffs of symptoms endorsed, or you can use certain algorithms to try to say that PHQ predicts a diagnosis of depression. So based upon PHQ predictions of depression, the rate of false positives was disturbingly high. Between half or 3/4 of people diagnosed with depression in a primary care office based on PHQ didn't have major depression based upon a standard structured clinical interview format. In this particular paper by Fisher, they reviewed prior literature, and their finding is not unique. Previous estimates say that between 40 and 60% of people with type 1 diabetes given quick screens for depression were misdiagnosed as having depression, when probably they were having what's best characterized as an adjustment disorder secondary to the medical illness, or general stress related to chronic illness translates into endorsing scores on PHQ. So I mean, this I guess gives maybe a worst case scenario. I hope it's not atypical, or I hope it's not predictive of general practice misdiagnosis, but it certainly illustrates that doing quick assessments based upon symptoms and jumping to a diagnosis based upon those things can lead to a lot of diagnostic error, which is very problematic, because the consequence then is that these folks are likely to be given antidepressant medications, which are probably going to be not wildly helpful and may actually make things worse disrupt their quality of life in terms of sexual function, gastrointestinal distress, putting them at risk for having akathisia or drug-induced manias or so forth. So it's a very big problem. Let me give you some examples from my actual practice world. I was referred a case referred a patient when I was working at a state hospital. The sign out from the referring hospital was that this young woman had schizophrenia, and she had been hospitalized for 3 months. The entire summer was spent in a psychiatric hospital, going through various antipsychotic medications to try to treat her alleged schizophrenia. She became my patient, and I noticed a couple of things. First, she had a master's degree in a scientific field, and between her episodes of psychosis had maintained a very high level of employment. That's not impossible with some in schizophrenia, but it's not common. And it's also not characteristic of schizophrenia that one will be fully resolved in symptoms to the point that they can maintain this high level of employment and then have a incapacitating level of symptoms. That an episodic psychosis made me think, could this be mania? And indeed, if you ask questions to the patient or her family, you will get a very strong family history of bipolar disorder. And if you ask about specific kinds of delusions or hallucinations, there were many that had a very grandiose kind of flavor. So it seems to me that we were really looking at a case of bipolar disorder, and I basically added lithium to her existing medicines. And whereas she had had zero improvement for 3 months, she began to have marked improvement within 4 days of lithium, and I discharged her in a week. There was another case that was sent to me as a referral for difficult, actually there were 2 cases I'll talk about, for difficult refractory severe OCD. The OCD diagnosis apparently was just based upon the fact that there were obsessions or compulsions. In the one case, the obsessions, when you ask the patient for details, were probably better described as just intrusive mental images that were very disturbing. They involved animals doing disgusting things. They didn't result in compulsive behavior. They were just very unsettling that these images were just sort of entering the mind. So it didn't sound like OCD once you got down to the level of looking at, does it match diagnostic criteria? In this particular case, I simply discontinued lamotrigine, and those intrusive images started going away within 2 days and abated completely within 4 days of doing nothing else than stopping lamotrigine. In another case of alleged OCD, the OCD diagnosis was given by what was compulsive skin picking. This patient had scars across her entire face for months of compulsive skin picking. So just on that, one would have thought, excoriation disorder or trichotillomania might be a better diagnosis to describe that. But there were no obsessions that the skin picking didn't relieve any sort of psychic tension from obsessional ideas. And in this case, I simply stopped the stimulants that had been prescribed for a supposed diagnosis of ADHD, and immediately the skin picking went away, and her skin cleared up within about 4 weeks. So that was a case where there was a side effect from amphetamine, which was mislabeled as OCD. Not uncommon. I've had many cases that are referred to me and billed as treatment-resistant major depressive disorder, and there was actually a very significant component of anxiety disorders that had been unrecognized and had responded poorly to SSRI treatments. So simply addressing the anxiety resolved the entire clinical picture doing that. And then I'm going to talk about this last bullet point in my final conclusion slide, but this made a very big impression on me when I was a medical student. I was following a neuropsychiatrist during a elective rotation, and we had been referred, or he had been referred a case that was on paper just very simple, just clear this person psychiatrically so that she can go and have a genetic screen, because Huntington's disease ran in her family, and she wanted to get tested. And so prior to a genetic test, whose results may inform you that you have an irreversible and lethal illness, the protocol required quote unquote site clearance. And she came into the office. This was an outpatient consult. She was, a very well put together lady from a wealthy suburb of a large city, very well dressed, very polite. Everything looked completely normal to me. And there was no history elicited of major depression, anxiety, psychosis, etc. At the end, I thought this was all going to be done in the end. At the end of this interview, the psychiatrist asked this mid-50s lady if she knew what today's date was, and she didn't know it. He asked, "Do you know what year it is?" And she got the year wrong. And then he just went with further cognitive screening questions, and she had a very dense dementia at that time. So she was able, despite not oriented to time, was able to get herself to a clinic appointment and so forth. But it turned out that this was a lady who was well into an Alzheimer's disease pathology. And my instructor told me, number one, always ask those questions at the end, or at some point, never forget to ask those general questions, because that will oftentimes give you surprising information. But he said he wasn't surprised, because in his assessment, he noticed that she walked in the door. She looked very well dressed, very polite. You wouldn't expect anybody with that appearance to have anything the matter with her, nor would you expect her to have a mustard stain on her shirt. And he noticed that she had a mustard stain on this expensive blouse that she wore. And he said that doesn't fit with everything else in the picture. So I was suspecting from the beginning that there may be something serious going on, because a person with this demographic doesn't show up to an appointment with a dirty shirt. And it turned out he was right. So asking everything, not skipping questions is very important. So as a reminder, psychiatric diagnosis, most diagnoses have the key symptom in their name: major depressive disorder, for example, obsessive compulsive disorder, attention deficit disorder. And all diagnoses, are based upon a lead symptom, a so-called criteria A symptom, which has to be severe and cause distress and disruption and has to persist for some period of time. However, as a gentle reminder, there are other criteria that are in every single diagnostic chapter of DSM. So in addition to having, the cardinal symptom, which, by the way, has multiple causes, for example, a depressed mood can have dozens of causes. In addition to having the cardinal symptom, there have to be other criteria met. So we're looking at a syndrome, not just naming a symptom with a diagnostic name. And also, last one, we'll always say, not better explained by the effects of medications, medical illness, drugs, or other psychiatric conditions. So in every diagnosis, we're told to ask a lot of other questions to make sure that we're not missing anything. So let me give you some examples of what things could be missed. Patient comes in, let's say, complaining of panic or anxiety. These lists, by the way, are incomplete lists. These are just some top-level ideas. Cardiac illnesses, endocrine illnesses, pulmonary embolism, pain, thyroid disease, cancers, and so forth can cause these symptoms. Fairly long list of drugs can cause them. You know, I think we know caffeine. Hopefully we do know that cannabis can do that for some people. Stimulants absolutely can. Popular over-the-counter medications can. A lot of asthma medications and so forth. Food additives, and the list goes on. And there's also people with schizophrenia can present with initial complaint of anxiety. I had a gentleman who did have schizophrenia, and his lead complaint was panic and anxiety, and he was concerned because people were following him around and putting stuff on his car and were implicating him in various plots. So a number of psychiatric illnesses can present with anxiety and panic, and one has to ask for these other symptoms to make sure that we're not missing something important. Same for depression. Very long list of medical illnesses can cause this, including nutritional deficiencies, autoimmune diseases, whole bunch of different drugs. Just to highlight, not infrequently, I see people that have horrendous depression that is caused by exposure to ciprofloxacin or fluoroquinolone antibiotics. They don't cause that for most people, but they certainly can cause that for some. So be advised. Other interesting feature, most people who take statins don't have neuropsychiatric side effects, but some people do. They're implicated in depression as well as in violence and suicide attempts. Smoking cessation drug, varenicline, and Accutane.
Hello.
Especially well known to do that.
Good, how are you?
And then there's again a host of actually a very long list of psychiatric illnesses can present with chief complaint of depression. And for example, then mania, we have again a host of medical illnesses. I want to highlight here tertiary syphilis. I'm not seeing that we're screening for syphilis all that much these days. It's a very cheap test, and you do catch still today cases of syphilis masquerading as psychiatric illness. So it's worth adding to just a default panel. Autoimmune diseases and so forth. Long list of drugs, notably any drug that can boost dopamine signaling. So we're talking about Parkinson's disease treatments, talking about ADHD treatments, and not that it's an ADHD treatment, but cocaine augments dopamine and norepinephrine signaling. Antidepressants, and some drugs like H2 blockers, anticholinergic drugs, and steroids. And there you have psychiatric illnesses. And psychosis, the list of medical causes is actually very similar to the list of medical causes for mania. Similar drugs can also produce psychosis, including cannabis and over-the-counter cough medicines. And a fairly long list of psychiatric illnesses can do this. So my point is, if somebody comes in with psychosis, it's not an automatic assumption that they have schizophrenia. If somebody comes in with features of mania, you should not jump to a conclusion that they have bipolar disorder and so forth. So how do we avoid this symptom overshadowing? It starts with, I guess, being skeptical of your first impressions and listening very, very carefully and asking a lot of questions. I told you, that noticing things that don't fit the typical picture. A mustard stain on a blouse is somebody who you would think would be mortified if she showed up that way, can be a clue, or a symptom that doesn't quite fit with the usual cluster. And it's imperative that we do good or have access to good quality physical and neurological exams, as well as do lab and imaging studies for people, and ask for every other thing. In this slide, I showed you about there was a massive false positive rate in PHQ assigned diagnosis of major depression versus structured clinical interview for diagnosis. This is the gold standard. It's usually used in research, although there are clinician versions that we could administer in about an hour. And the magic of SCID is that it does guide you through every single diagnostic category. You ask screening questions, and if they answer the screening questions, say for depression, you go to finer toothed questions to try to parse out whether diagnostic criteria are met for any form of depressive disorder. If they don't, answer positively to a screening question for depressive disorders, you simply move on to the next chapter. In this way, following this little booklet, you're guaranteed that you're asking about every single symptom in terms of a screening question, and do follow-up questions where the screening question is positive. So asking about all symptoms that you can think of from all the major diagnoses is necessary if you don't want to get wrong diagnosis. My advice to anybody is I'm disturbed by the number of job offers or recruitment blurbs I get saying, and you get 45 minutes for a new intake. And so this is wrong. You cannot do this job by talking to somebody for 45 minutes and coming up with the right diagnosis. Or if you, I mean, you can do this for people that are very simple, but by the time they're referred to a psychiatrist, they've usually failed 3 rounds of prior assessments. So you're guaranteed, if you agree to this as a working condition, you're guaranteed to wind up doing eventually missing things. So push back on that, or if you're assigned to that, then make sure that you let people know that you're not, you might not give them a diagnosis at the end of the first session, and take your time to make sure that you do get the complete history before coming to diagnostic conclusions. And also don't forget psychological factors to explain symptoms in addition to just the